Namaste to all. Good morning to those who are in the USA and good evening to those who are in Nepal. I'm truly very honored to welcome you all to today's webinar on COVID, fighting COVID-19 experiences and knowledge exchange from the frontliners. I'd like to quickly provide a background how we started and the objectives and program agenda for today's webinar. How we start? First, Vishal Pradhananga, Prakash Kardil, and the whole team are very much concerned as more people are dying and most of their lives could have been saved. So we thought that of having a common platform, sharing experience of dealing with COVID-19 pandemic and willing to help in Nepal. So what we have learned throughout the period, throughout the COVID-19 pandemic, so when it has started in Nepal, there was a lockdown imposed and our focus was to stop the spreading of COVID-19. But now our focus is on both stopping the spread as well as saving the lives. And we have also learned that early interventions are necessary to prevent patients from becoming critically ill and prevent hospitalization. Definitely, we have also learned that patients and healthcare workers need to coordinate and work together to save lives, to make people feel safe, and to provide relief. So for that, all the three organizations come together and we thought of collaborating together to do something better for saving the lives. And the Small Earth Nepal, Rotary Club of Kathmandu, Nepal, Yale New Haven, Health Lawrence and Memorial Hospital are joining together to start doing something. And this is the first webinar that we are having today to share experiences by healthcare professionals of Nepal and Yale Hospital regarding the COVID-19. And we have thought of having second webinar that is for the public, general public, which will be broadcasted live. And the third activities we have thought of having awareness campaign by publishing informative short cartoon videos and pamphlets, both in Nepali as well as other languages. So let me quickly introduce the three organizations which we have joined together to do something for saving the lives. And definitely the presenters from the speakers from the New Haven Health will be talking. So I won't spend much time talking about that, but let me say something about the Rotary Club of Kathmandu. It's the first Rotary Club in Nepal, and it has already started working on saving the lives by different activities in Nepal relating to the COVID-19. And the third organization is the Small Earth Nepal, which is an NGO working in a research and awareness, as well as capacity building in the Asia Pacific region. And it started with some campaigns and some support to the government related to the COVID-19. But now with this whole team, we are trying to work on making people aware on how to save lives. So today in our webinar, we have mainly 4 sessions. The first one will be the experience sharing by the Yale New Haven Lawrence and Memorial Hospital team. And the second part will be the experience sharing by the Nepali doctors. And third one will be the interaction and the question answer session, which will be moderated by Dr. Pradeep Pandey. And finally, we'll conclude with some way forward and the summary of the whole webinar. So with these two, quick descriptions and the background, I'd like to request Dr. Pradeep Pandey to lead. Thank you very much. And once again, I welcome you all for today's webinar.
Uh, thank you, Dr. Dheeraj. Namaskar, namaste. Good evening to friends from Nepal, and good morning to our friends from USA. And warm welcome to everyone. Before saying anything, I would like to take an opportunity to thank all the frontliners in behalf of RC Kathmandu and Small Earth Nepal who are fighting for us, even after knowing their service can take their life and can risk life of their loved ones. I am Rotarian Dr. Pradeep Pandey and moderator of today's program. It gives me immense pleasure and feel honored to be a part of this webinar. Today's topic for this webinar is Fighting COVID-19 Experience and Knowledge Exchange from Frontliners. Thank you everyone for taking time out for this session. Without delaying much, I want to get straight to the today's program. We have divided our today's program in two sessions. First session include presentation from speakers, which will be approximately of 1 hour. Then next session includes discussion and sharing experiences from our eminent personalities and the doctors in the audience. So first of all, we'll hear experience from Yale New Haven, Lawrence and Memorial Hospital team.
Hi, everybody. Thank you for welcoming us, and we actually are very excited to be able to Zoom with you in Nepal. This is the first one I've done, so thank you, an international connection. So thank you, and thank you to Bishal here locally, and also Dr. Kandil, to very, very valuable members of our clinical team, and all the frontline workers. Thank you as well too. So just a quick introduction, and then I'm going to actually toss it to my teammates. So my name is Oliver Mayorga. I'm a physician, emergency medicine trained, but these days I do mainly more hospital administration. And so what I wanted to do is give a little bit of background also about our health system. So as you saw in the name, we are part of Yale New Haven Health System. Although our hospital is actually Lawrence Memorial Hospital, which, as you also saw, is about 280 beds and has a lot of different subspecialty services, but in the United States is essentially considered a middle-sized community hospital. Now, we're part of a larger system that has an academic medical center that is also part of Yale University, as you know, also very large university here in the United States. The academic hospital actually has 1,500 beds, so very big, and the actual health system, which is a combination of 5 to 6 hospitals, actually is the largest in Connecticut, which is along the coastline in the northeast part of the United States. And so that is the environment we actually work in. And we also, that does actually play a little bit into lessons learned in the pandemic. And so I'll share with you a little bit about our incident command team, which actually is a system-wide incident command team that puts together operational leaders across all the hospitals and the health system, but also it connects with our state as well too. I won't talk too much about national politics. That unfortunately left a little bit to be desired in coordination in the United States for COVID-19, but we'll leave it at that. So from a statewide standpoint, we actually started seeing cases increase in the springtime, I think similar to you as well, but in particular March. In the middle of March is when we began to shut down things. So schools, elective surgeries, a lot of regular activity, medical activity stopped in March. And interesting enough, in the United States, COVID-19 first really showed up in the West Coast, in the Northwest, specifically in Washington State, but actually very quickly became out of control in New York City and all the surrounding heavily populated areas, and then began traveling. And New York City is only maybe an hour and a half, 2 hours from us driving, and then began actually traveling up the main highway towards us. And so we saw it go from west to east, really along our health system. And luckily, Lawrence Memorial in the first wave, I would say we saw a good amount of COVID patients, but we were not, I would say, overwhelmed, although certainly other hospitals in the highly populated areas like New York City were really overwhelmed. They ran out of intensive care units, ran out of doctors, ran out of nurses. We actually were able to send some of our frontline staff down to help them more to the west of us. And so over the summer and actually early fall, it actually got pretty quiet around here. There were many days we had nobody with COVID in the hospital. And more recently, actually in the last 3 to 4 weeks, now we have, a higher census than we ever saw in the springtime. So the difference though is in our springtime in the United States, the rest of the United States was doing okay. So they were able to send frontline workforce, nurses, physicians, if we needed them, to our area. That is no longer the case because the rest of the country here is now also in a terrible state. So these days we're looking at higher volumes of patients that need to be admitted. But frankly, we are having situations with frontline staff. And so we're trying to think carefully about how we utilize our clinical workers, and also recognizing at this point, everybody is very tired. They're very burned out, is our phrase we use here. And there are actually people who are stepping away from healthcare because it's just been too intense. So I'm actually going to actually pass it on to Dr. Torres, who's going to talk a little bit about what we've learned on our testing front and also our surge capacity for excess volume. So thank you.
Thank you, Dr. Oliver. It was a great information and great experience. Now I'd like to call upon Dr. Kevin Torres, who is Associate Chief Medical Officer. Dr. Torres.
Yeah, hi. My name is Dr. Torres. Again, definitely wanted to thank Bishal and Dr. Kendall for setting this up. So two of the areas that I was involved with and continue to be involved with is our surge, or how we expand our operations at the hospital and into the system, and testing as well, and how we go about testing our patients and how that's evolved. I'll start with the surge areas. So we started probably February, March, well, maybe even a little sooner than that, January, talking about our surge and how we would expand our hospital. We were actually bumping along pretty well for a while with elective surgeries, and the hospital was busy, and our emergency department was holding probably 9 or 10 patients every day. And so looking at how we would expand was difficult. And I would say at first we started at looking at non-traditional areas, whether that be conference rooms, or even we looked at buildings outside of our hospital where we could expand to. There was a nursing home that was empty in the area. We went and looked at that area, and our homeless shelter expanded into there so we could have more space. But as we looked into all these different areas, we quickly learned that you need obviously the staffing to be able to use these facilities. So we had grand plans of many conference rooms and outside buildings. We had different colleges and universities offering us their auditoriums, but without the appropriate staffing, it was difficult. And I would say in the first wave, staffing was probably a little easier to come by because we actually brought down our elective surgeries for a few weeks. And that gave us extra staff that we could put in different areas and use these non-traditional treatment areas. What we ended up doing was working with the system. Like Oliver said, there's about 5 or 6 hospitals, and we came up with numbers that our floors and our ICUs, intensive care areas, could actually take for patients, and what we could actually staff for multiple days in a row, and not just one evening or anything like that. And so we came up with caps where we would legitimately be able to staff up to and continue that staffing. And then at that point, that would trigger calls to the rest of the hospitals to try and get some movement within the system to move patients to a safer area and keep that staffing going. And that's not just nursing, that's also physicians. We looked at expanding our physician coverage and getting, we did emergency credentialing, where we got physicians from other hospitals to be able to come to our facility to help us out. Like Oliver said, in that first wave, we were able to actually send physicians the other way. Some of the emergency physicians closer to New York City, the hospitals there got overwhelmed, and some of those physicians got sick. So we were able to send some emergency physicians that way. So I would say staffing was a big deal. And I would say, again, now we're continuing with our elective surgeries. We look at what's being done each day and what maybe we could scale back, or what might end up in our intensive care as that's full. But again, staffing and what we could do on a continuous basis is what we look at and what we plan for, and we work with the rest of the system to then send patients appropriately. So that was kind of our surge area. Our testing, I don't know what your testing's like. I'm sure we'll hear about it. We started out in February, March with fairly limited testing, and that's probably why, that's one of the reasons why we certainly couldn't do a lot of surgery at the time. We had one particular platform that worked pretty well. It was a pretty quick test. It was called a Cepheid. But our biggest problem, and I'm sure you've dealt with it as well, is getting the appropriate swabs, reagents. That can come and go by each week. That can change. And so that changes the way your workflow is and how you can treat people. What we've done as a system, again, amongst those 5 or 6 hospitals, is order, we're able to order more of in a bulk type situation. And then that they try to get multiple platforms to do our testing on, so that if one reagent swab runs out, we have a different one we can turn to. On top of that, I'm sure you're dealing with as well as the turnaround time. So, you know, some of our tests, we can get a test back in a couple hours, and some take, you know, depending upon by the time they get picked up, flown to a lab somewhere else in the country and then run, could be 3, 4, 5 days. And so that certainly changes how you use the testing and how that helps as far as putting patients throughout the hospital. So I would say trying to spread out around multiple platforms has been our biggest, the biggest thing that we're trying to do. And that's been able to keep us pretty well able to continue to test our patients and keep our staff as safe as possible. I think that's it for me.
Thank you, Dr. Torres.
You're welcome.
You said we also have a lot of problems, and it was like a first wave in September and October. I think it was a big burden to Nepal, and we don't have hospital beds for even for the critical patients. But at that time, government was like pressurized to keep the patients of corona in home isolations who have mild symptoms to moderate symptoms to the home isolations itself. But I think in winter now, I don't know, but our Nepalese doctor will say, but I think it's a little bit more comfortable than in September and October at now. And it is also because of the tested that we are doing less. Like initially, actually in September and October, we are doing like 20,000 PCR tests, and we have now lesser tested in nowadays. And initially, it was also very difficult to have a PCR test because government was only doing it. But later on, government gave facility to the private hospitals to provide or to keep PCR machines. So after that, it becomes a little bit easier for all the Nepalese. Otherwise, we need to have like wait for 3 to 4 days or 5 days to have a PCR testing, and that was a big difficulties. Okay, thank you. So it was a great information. So I'd like to request and call upon Dr. Cynthia Tucker, who is MD in Emergency Department. Dr. Cynthia.
Yes, thank you so much for having me. I'm honored to be here with you all to share some of our experiences. I'm an emergency physician, and I split my time between the emergency department working clinically as well as doing administrative care of the department. And I'd like to split my talk today into 2 parts, and to talk first about some operational processes that we have worked on during this pandemic, and then about some of the medical management and disposition of those patients. So first, the operational processes. Start about PPE. PPE was a very hot topic in the beginning of the pandemic. As you probably know, the guidelines from the major organizations changed a lot in the beginning, and that was very hard. But now we have consistent guidance, and we all healthcare workers keep a mask, a surgical mask on at all times. All patients are masked as well. And we also, all healthcare workers also wear eyewear as much as possible, and certainly during the direct care of patients. We have 2 negative pressure rooms in our emergency department. And so we strategically placed our PPE don and doff stations outside those rooms where we previously did not have anything. And the concept of having a physical space dedicated to PPE, don and doffing, and the actual steps and process was really key. We had done some of that education prior with the Ebola scare, but it never thankfully came to fruition. So we certainly were not really experts on that. And that was identified early on as a potential way healthcare workers could become infected through the doffing of that infected PPE. So that station with clear guidelines and with discussion at our daily huddles was really an important part of our early pandemic preparations and care. And that station includes a cart with all the PPE gear. It also includes a table so you can take off your stethoscope and other things that need to be disinfected. And it includes a trash can and then your disinfectant wipes. And the last thing that doffing area also includes, especially early in the pandemic for the first several months until we were experts at proper doffing technique, was a doffing coach. One of our ED techs already was a bit of an expert on this, and he trained some others. And we had direct visual watch of people taking off their PPE and direct guidance. No, don't touch that. Resanitize your hands here before you touch something else. And so that really put a lot of focus on it and allowed us to be as safe as possible. The second area of operational processes is cohorting. We did try to keep all our low to moderate acuity COVID suspect patients in one area of the emergency department, which had some private rooms, which we do not have throughout our entire department. So the low to moderate acuity patients could be taken care of there and hopefully quickly dispositioned. The very sick patients needing emergent treatment went to our negative pressure rooms if available, or another major treatment area. And that goes along with the idea of clustering care. So this applies to both the nursing tasks, clustering all their care, getting prepared and thinking in advance of all the things they want to do in that one fell swoop of going in, getting the line, IV line, getting the blood work, getting the urine, getting the EKG, putting the oxygen on, kind of doing all the initial assessment at once as opposed to somewhat piecemeal. And for me as the physician, it really did change the way I had to think if I was going to go in and get all, covered in my PPE. If I was going to do an intervention such as an airway or get a central line, that I would do all those things together and be prepared with all that different equipment, whether it's the glide scope. We did preferentially use our video laryngoscopy over direct, as that decreased risk of direct aerosolization, excuse me, as well. And getting all that equipment together all at once. So that represented a big change and also a big opportunity to decrease risk to yourself, the healthcare provider, as well as minimize PPE use, because you can really burn through a lot if you're not careful in that way. And the last operational topic I want to share with you is the use of telehealth in the emergency department. So previous to this pandemic, we did not utilize telehealth in our emergency department, and now it is commonplace and even expanding to patients who haven't even arrived in the emergency department. So we primarily utilize telehealth for secondary evaluations, discussion of results. Those telehealth units are equipped with audiovisual capability, and we use a platform called InTouch. There's several different platforms. We've also used the Amazon products, the Echo Shows. We were able to connect those and have audiovisual communication in almost every room for a period of time. And even some patients who didn't require a direct physical evaluation only had a telehealth visit, even when they presented to the emergency department with the provider. And so that's allowed us, again, to minimize PPE usage. We were really careful because we were, all very concerned and scared beginning parts and middle parts of the pandemic, would we have enough PPE? Even as a big health system and with Yale as a partner, would we have enough? Would we run out? And that was a fear for us. And that was really a very important way we tried to conserve what we had. And that telehealth usage continues to evolve, and I continue to work on that. And like I said, we're rolling that out to new platforms. And certainly that could be a whole nother talk, the ambulatory management with telehealth. But I'll move on now to briefly talk about just a few medical management pearls. And I'm not sure, can I share my screen? I'm going to try to share my screen here. Is that okay?
Yeah, let me just quickly make you co-host.
Okay, excellent. I'm just going to briefly share this. It's our current pathway. The medical management of the COVID patient in the beginning was somewhat challenging. There was a lot of gray areas, and now it's become intellectually not as challenging. It's sort of cookbook, if you will. Are we good? Okay, yeah. Thank you. How are we doing? Can you see that?
Great, yes.
Okay. So this is our current ED COVID treatment and management pathway. It's still work in progress. It's still changing and morphing, but it allows us to kind of have a common set of knowledge and expectations to go through. So you start with, concerning for COVID, a patient concerning for COVID, and you can kind of go down the pathway. We do focus on whether the patient has goals of care with CMO, and that would allow you down a different part of the pathway. I'm just going to go down to here. And we focus on a SAT of 94 as somewhat of a crux there. If their SATs are less than 94, they can't go into the mild pathway. They go into the more severe pathway. And so if they're less than if their SATs are more than 94, they can be ambulated. And if their SATs remain over 94, they can be discharged without further workup or treatment with appropriate home care, isolation, follow-up instructions. When their saturations on room air are less than that, or if they're, obviously unable to do that, and they're very sick, then we have an initial workup, which includes a chest x-ray, some labs, your COVID PCR test, blood cultures. We are gentle with the fluids. So we start with a 1 liter bolus, as opposed to a little bit more than that for a usual septic patient. And then our oxygen is focusing on high flow. Is our main modality for patients requiring a lot of oxygen, or BiPAP if they need a little bit more pressure. And just going down, I know this is a lot to take in, but just going down, we have a little bit more just to kind of show the how the guidelines are very straightforward. Depending on your oxygen need, you fall into severe or moderate. And then there's some risk calculators to determine your risk of decompensation in 24 hours to help guide your disposition, whether to an intensive care unit or a step down or floor. Some MD Calc has some of those severity calculators, and there's some that Yale has come up with on their own as well. But that has just standardized our care and allowed us to know which patients we think are going to decompensate the fastest, so we don't have as many airway emergencies on the floor as we perhaps wouldn't if we didn't have this type of information. The last topic I'll just say is that we have developed the ability to send a patient home who's thought to have mild disease, at least in the beginning, with a pulse oximeter, and then to follow up using a telehealth platform with a nurse to check on those oxygen saturations on a daily basis to identify if they're starting to get sicker before they're crashing. And so that has also been a successful addition to be able to home disposition patients from the emergency department and not overwhelm our hospitals. So I will stop there. Thank you so much for having me.
Thank you, Dr. Cynthia. It was a great effort and experience, and it was so interesting. I just loved your presentation. In contexting Nepal, we have actually isolation room in emergency in later on in some of the hospitals, not in everywhere. Like whenever any patient suspected COVID patients to a hospital, we have that isolation room where we keep a patient and do a PCR test, and if it becomes positive, we refer to a COVID ward or COVID ICU. But it is not everywhere. And about PPE also, most of the staffs are wearing, but I don't know every staffs are wearing PPE in emergency or not. But when I was admitted in hospital as a COVID patient, what staff used to do is like they used to come to me with full PPE. They used to give medications, IV injections, or all the things that whatever they want. And all the after they do all these things to all the patients who were admitted. And after that, when they go to their room, then they become a normal, like normal wearings, not like PPE. Like they used to have a mask and face shield, but not PPE. I don't know what is the trend there. And for audio visual room also, we also have audio visual room, no, but not in emergencies. We have actually in the hospitals where we used to keep a mild to moderate COVID patients. So from there, medical officers or doctors used to ask like what is the conditions. If some problems is there, like medical officers go with the full PPE and talk and deal with them. So that was the thing I just want to tell. And for the treatment options, I think Dr. Kavita who will tell you more about that those things. So thank you so much, Dr. Cynthia. It was very interesting. Now I'd like to call Dr. Neil Duig, who is a pulmonologist and did his MD in pulmonary medicine and critical care medicine.
Hi guys, can you hear me?
Yeah, yes, sir. Yes, sir.
Well, my side is not as well put together as Dr. Cynthia Tucker's, which is not an uncommon thing. But my side will be day-to-day management of it every day for the past 9 months in various different hospitals. So the ICU side of it has been very interesting. My best comment on it is everything I did in March, I no longer do in December. Almost every single thing except intubations is different. My main notice, what I've noticed the most, and I agree with Cynthia Tucker, is the issue. There's now 2 cohorts of patients. The first cohort of patients are the very mild people that are young with minimal settings. They come in, they get a little high flow, they get some medications. They're in for 1 to 2 weeks and they'll survive. The next set of cohort patients is what we are dealing with, which is the older comorbid people with multiple comorbid conditions, that if I intubate them, their mortality rate is 80 to 90%, and most of them do not. If they have more than one system down besides anything pulmonary, their mortality rates are massive. The other thing I've noticed is it is the slowest disease process I've ever treated. They are intubated, paralyzed, proned, and they stay on a ventilator for 2 to 3 weeks at all if they ever come back off it. And it rapidly uses up all our systems very quickly. And that's what all the other hospitals dealt with. It was just complete overload, but they weren't that complex. They just took forever to fix if they were at all in any comorbid conditions.
Dr. Neil, just to, sorry for interruptions. I think you're blocking your microphone with your hands.
Okay.
So, yeah.
I will change my mic out. Sorry, that's why I asked you. Hold on 1 second. Give me 2 seconds, please. Try. Can you hear that?
Yes, it's better than earlier, though.
How about that? Can you hear that?
Yes, good. Great. Thanks.
Sorry, I changed mics out. So short and sweet. I apologize for that. I tried to test it beforehand. I won't belabor the process very quickly. What I will just say, short and sweet, if you guys didn't hear me, was 2 cohorts of patients. The older patients are not surviving. If they're intubated for more than a week or 2, if they are greater than, I'd say in the mid 60s, my survival ratio is maybe 20%, 10%. It is using up all our systems very quickly. It's not overly complex. My main state that I use is high flow, high flow, high flow. I now am taking them to multiple systems of high flow. Our respiratory department is very helpful with our high flow patients. When we started this, we intubated way too early. We intubated them on minimal settings, minimal high flow. Then with the second wave, we've been intubating too late. So what's been happening with us is we've been taking our high flow systems, which run approximately 90 to 95% FiO2 and 60 liters per minute. And we have been running those to the absolute limit every day, 4 and 5 people a day. The problem we have been running into recently is they crash very quickly at night at any time, and that's putting a lot of strain on systems. So we're kind of starting to head backwards in our institutions to a little more elective intubations, rapid proning paralysis, and that is, once they're intubated, is lasting 2 or 3 weeks on average. We are also using a lot of video, even on daily examinations, just because going into those rooms is very dangerous. We have a lot of everything is viral filtered. And the other thing that I'm doing a lot is immediately after intubation, they get all their lines, they get everything. It's all immediate. The second I intubate them, I prone them, because if I don't, they crash incredibly quickly, and it's a very limited period of time. So that's just more of the day-to-day management. The medications keep coming and going. The only ones we're still using is remdesivir and Decadron, and all the other medications I used in March are no longer on our protocol lists anymore. So it's interesting, we just keep moving, and I'm hoping for my vaccination shortly. And that's kind of really a quick, rough description of what we're doing. And otherwise from that, it is working in teams. And the other thing is backup groups of people. This is going through our staff very quickly. It is exhausting them, and they are getting very tired. So it's always nice to train multiple people to do the same job. So that's my ICU summary. That's all I got.
Thank you, Dr. Neil. It was very, very interesting and informative presentation. I just loved that and get chance to learn a lot of things, but I'll not speak much about the management part because we have a pulmonologist and other doctors who are working directly to the corona patient. So I just thank you. Hope they will ask some of the questions, or they might have queries. But yes, initial days we also have very much difficulty to have a remdesivir in Nepal. But now I suppose we are getting remdesivir quite easier way. Thank you. Now I'll request Dr. Ellen Bruton, an infectious disease specialist, to keep his views and experiences.
Hello, everybody. Namaste. Can anybody hear me?
Yes, we can.
I don't have a camera. I want to share my screen.
Just a minute. I'm just making you a host, and you can do that.
Okay.
Yes, sir. You can go ahead now. You can share your screen, Dr. Ellen.
Is it working? Can you see it?
Yes, we can.
Okay. Good morning, New London and United States. Good evening, Nepal. Namaste, everybody. I just want to go briefly over our geographic characteristics. We are located in the northeast. I don't know if you see my cursor. We're servicing two small hospitals. One is Lawrence Memorial. The other one is Westerly, in two contiguous states, Rhode Island and Connecticut. We are small population wise, just few million. This is a map of Connecticut showing density over this corridor, and the two large health systems, the Hartford Healthcare in the middle and the Yale New Haven system on the coast. We are towards the right of the screen, Lawrence Memorial and Westerly, and the size of the circle kind of mimics the bed size. We're about So we're servicing about 250,000 people, more in the summer. Lawrence Memorial has about 280 beds, Westerly about 80, and they're pretty much built the same way with ER, with intensive care units and regular floors. In the Lawrence Memorial, we have a dedicated respiratory floor where we admit the COVID patients. The provider ratio is consistent with the bed allocation, as you can see it here. The additional staff is represented by the nursing team, the ancillary staff, the respiratory therapist, and the other services. In general, I think the epidemic has spared us, as we were never overwhelmed with. We had an occupancy rate of about 25% of the hospital beds with COVID patients. We did experience the shortage of the personal protective equipment, as other speakers have said, especially in the beginning of the pandemic. We have implemented the telemedicine stations, which at least on the floors and at least in my experience, we have not used significantly. This slide wants to say something about the Connecticut statistics. It's a flashpoint of what is happening in a single day in Connecticut, where there are about 1,200 hospitalized patients in the whole state, whereas a minority is happening in New London and Westerly, where we're working. So far, the state prevalence of the COVID cases is about 4%, and the death rate is about 3.5%. And that is similar with New York. That's another way of looking at things. On this center of the screen, we have the day-by-day census of the hospitals of both Lawrence Memorial and Westerly. And this has ranged about 170, 180, 200, with the COVID cases represented by this blue line, with a first peak in spring, followed by a second peak in September with the school opening, and the third peak in November after Thanksgiving. Well, like somebody else said before, we did not know a lot of things, and we learned few things through the epidemic. We learned, for example, about the ability of the infection to be transmitted in the asymptomatic or pre-symptomatic state. We learned about the super spreading events, which are highly efficient transmissions when the patients conglomerate indoors and stay there for long periods of time. We found out that exposure to the open, the so-called indirect contacts, are less likely to transmit. So are various graphics. The efficacy of transmission is usually represented by the size of the inoculum, which can be counted with that RNA testing that we have, although it's a qualitative test and not a quantitative test. We think that the transmission starts before the onset of the clinical symptoms, and it peaks rapidly in the first few days of disease, to diminish significantly with the convalescence. We found out that there is extended viral shedding, which can be found on repeat testing. We repeat testing 1 week, 2 weeks, 3 weeks after the initial positive, we still find a positive test. This does not necessarily transmit into infectiousness. It's just a marker of difficult clearance of the virus. And we think that the prolonged shedding is associated with age and immunosuppression, not only with the disease severity. These are my clinical pearls. I learned that COVID comes in many shapes. The most common presentation, which is now managed in the community, is the fever, some curvature, some cough, with no major respiratory discomfort, and they can be managed with symptomatic treatment. In general, prognosis is given by the underlying health status, but we found out that immunosuppression is not necessarily a high risk, as it is, let's say, lack of stamina or pre-existing respiratory failure from COPD. A lot of cases, like I said, present with just an upper respiratory illness, with sore throat, with nausea, with lack of taste. There is the respiratory presentation, sometime disconnected from the radiology, meaning the X-ray looks worse and the patient is better, or the other way around. There is a procoagulation cascade, and the most feared presentation is with the acute respiratory distress syndrome and the cytokine storm. We found out that monitoring the inflammatory syndrome gives some reassurance on the clinical side. We have witnessed several psychological reactions to the clinical presentation. One was the tendency to attribute everything being COVID. Patient with fever must have COVID, even if there was a different reason visible. We had negative tests. We needed to repeat them until we figure out that we're dealing or we're not dealing with COVID. And sometimes we used up to 6 tests to do that. I noticed that in the hospital, whereas the infection control policies were very strict, they relaxed, especially during the PPE shortage. We found that as the pandemic progressed, we have become tired, we have become overwhelmed with data and anxious of the overall uncertainties. And whereas we had hope for a vaccine, I have noticed a fear of the vaccine at the same time. During the summer, as the disease load has disappeared, so I just want to say there is a definite association with the outside temperature. I also want to say that the anti-inflammatory medicines we have used, be that steroid now, be that tocilizumab in the beginning, we have definitely saw an improvement of the inflammatory response. And anecdotally, we have seen how people with a procoagulation picture has improved. In my opinion, the most benefit of therapy is done by the management of the airway. Like Dr. Duhigg said earlier, give them oxygen and make sure that the ventilation is taking place. In case we need to prone, we should prone. The supportive treatment is the second most important because that deals with the symptoms. Sometimes it's not related necessarily to COVID, such as dialysis, such as the empirical antibiotics, such as the anticoagulation. This slide, I'm gonna point to the fact that in hospital, we have at least 4 levels of exposure, and that is paralleling the degree of direct interaction with the patients. The highest transmission comes from the assistance from the patient care or from the direct administration of procedures. The non-procedural provider evaluation, such as my interactions with the patient, the non-patient care, such as the secretary on the floor, is much less in terms of potential for transmission. At this point, after 9 months, I do not know if I can strongly recommend any specific therapy. We have seen how we used in the beginning a plethora of agents said to have in vitro activity against the virus. We have given them up serially: hydroxychloroquine, azithromycin, protease inhibitor, convalescent plasma. I think the next one to give up will be the monoclonal antibody, but I cannot speak up fully because I have not seen it in use. It was just approved recently. The remdesivir, I don't know if it works. The studies that I have seen and my personal experience says that the number needed to treat is something in hundreds, which makes the utility of such a medicine not a very strong one. What does work is the prevention of the cytokine storm, either through IL-6 inhibition, through the tocilizumab, an expensive product, or through the use of steroids, which are much less expensive. And the number needed to treat for steroids is in a single digit sometimes. Any chemotherapy produces immunomodulation and prevents the cytokine storm. So that was the explanation why we did not see any immunosuppressed patients with severe forms, at least in our experience again. What works also in the community setting, not so much in the hospital, is the social distancing that has been implemented since March, and especially the universal acceptance of the masks by the general public. The alternative is lockdown. So I think if you can educate the public to wear masks, you won. The problem with the mask is it doesn't matter actually what masks, although there is a difference. I think the masks, once used, once placed, should not be touched, which is difficult if you continue the day-by-day activities. Speaking, for example, changes the position of the mask. I want to share with you my personal experience. Usually, being an infectious disease doctor and seeing people with respiratory symptoms, usually every year I had at least 2 episodes of a contagious infection, an upper respiratory illness. Didn't prevent me from working, but it was making me symptomatic. One was in the spring, one was in the fall, when the weather was changing from when the temperature was changing around 0 degrees Celsius and the freezing was happening. This year, because I had to wear the mask, I have felt the best I have in the last 10 years. I think one of the last slides is what to do when you need to make room and you need to discontinue the precautions. There are several facts and several observations that have allowed us to implement this clinical decision, which is CDC based, because the infectiousness has diminished or is diminishing greatly during the convalescent period. We can stop the isolation after 10 days, 11 days from the symptom onset, on condition that there is no fever in the last 24 hours and there is clinical impairment. I'm sorry, there is clinical improvement. The duration of precautions probably should be longer if the patient is immunosuppressed. And vaccination indeed is due to start this week. And I wish you all good luck. And thank you.
Dr. Pradeep, you are muted. Please unmute yourself.
Sorry. Dr. Ellen, thank you so much for your presentation. It was very effective, and as you said about basic therapies, transmission efficacies, about the community management, psychological issues. I just want to say some of the things, like as you said in your state, like it's a death is of 3.5%. In context to Nepal, it's less than 1%. I don't know what's the region, but yes, we have challenges of having not able to make proper COVID ICUs and non-COVID ICUs in our hospitals. That is quite a big challenge. And psychological reactions, being myself as a psychiatrist, I have seen a lot of patients who is having corona positive, and during a corona period also having infected period, they have a lot of anxiety period, like due to the uncertainty of their own health, what will happen to them. And sometimes even only having a shortness of breath, they come to hospital like if I have some corona symptoms. So most common symptoms is like insomnias, anxieties, depressions, all of the things are there. And suicide is also quite increasing in Nepal after the corona has evolved. And for the mask, I also feel that the way of wearing mask properly is more important, as you have said. but it seems difficult to make it for the younger generations. And another part is to have that discrimination issues. Once you have a corona, people are like a little bit hesitating to talk with you, or being a little bit distance, maintaining distance. So that is the problem. So I'll end up here. Thank you so much, Dr. Ellen. So we have a last speaker from Yale Hospital, who is Tammy Sommer, who is a manager of respiratory care department. We're expecting to know some administrative experiences from him. Dr. Sommer, Tammy Sommer.
Hi, namaste. So I'm Tammy Summers. I am the manager for cardiopulmonary services here. And what I'd like to say is that the ability to share information across any kind of network has been essential in being able to take care of patients. So as being a smaller hospital in a part of the system, we weren't hit as much as our counterparts were, but we were able to learn a lot from our counterparts, so that when it did hit us, we were more prepared. So what we noticed during our first wave, we would have COVID patients come in, and they would quickly code. They were cohorted on one floor, and we noticed that every morning there would be a code, which we would have to provide resuscitation for. So one of the things that we implemented here that was incredibly successful was we had a therapist assigned to that floor, and they're in charge of monitoring trends of watching their oxygen usage. And as their usage would go up, then we were able to intervene earlier. Those patients, even though they may be on 2, 3, 4 liters of oxygen, and they were oriented, alert, we would also prone those patients early on. So before they hit ICU, we were doing proning and high flow oxygen on the patients, and we saw great success with that. And we continue to do that currently in this environment, in this second wave that we have here. The respiratory therapist, they're essential in managing, taking care of the patients with our ventilators. We've also seen that some of our patients tend to be out too long, so that when they come in, that early intervention may not be possible. And as Dr. Duhigg spoke earlier, we are depending a lot more on high flow, and then all of a sudden the patients crash. So we're looking into that to see what we can implement to try to look at the trends to see if we can counteract that, if at all possible. But I think one of the biggest successes that we've had is being able to spot early on and intervene early on those patients who are mild to moderate, and to prevent intubations, gathering people who may not be frontline responders, like we used our physical therapy, occupational therapy departments as proning teams, so that they would come in and they would help respiratory therapy and RN, and they would prone those patients on a daily basis. So as we met in the morning, we would discuss patients on the floor and deem which patients were appropriate for proning and intervention. And then we would plan that out and then implement that plan. And we had great success with that. And I think that it's incredible that we can share knowledge. Like I said, no matter where the knowledge is from, this is new. This is something no one knew about. So anything that can help one another is definitely fantastic. And I'm going to say this, Dhanyavad. I don't know if I said that right. Thank you.
You did, Tammy. Thank you, Tammy.
Thank you, Tammy Summer. So I know there must be a lot of questions coming in your head. We'll provide this opportunity after we complete first session. We are also getting a little bit late. So thank you, Yale Hospital and its entire team. It was quite effective presentation from you all. So now I request Professor Dr. Kavita Hada Batazu, MD, who is working in emergency department in KIST Medical College. So I personally know her and got opportunity to learn many things during my medical officer training. So ma'am, it's your turn.
So thank you very much, Pradeep. Namaste, and I heartily welcome you all, both my national and international colleagues and my dear audience. First of all, I would like to express my heartily thanks to the organizing committee of this webinar, who has provided me the privilege to share my experiences during COVID in this esteemed platform.
Dr. Kavita, maybe you can.
It's okay now.
Yes.
So this is the place where I work. It is a KIST Medical College teaching hospital, established in 2006. It is basically 550 bedded hospital located in Gwarku Lalitpur within the Kathmandu Valley. In order to reveal the highlights of the COVID-19 in Nepal, the first case was detected in January 23rd. Basically, this might be the first case in the South Asia. In order to curtail the spread of the virus, government has announced the nationwide lockdown for approximately 4 months. And the first mortality due to COVID-19 was on 4th of May. Until date, we have more than 250,000 positive cases, out of which more than 95% had already recovered, and that is 1730. That is less than 1%. So challenges during the initial phase of pandemic is tremendous, basically fear and insecurity. So as a healthcare professional is not spared of. Hopefully, not only our people, but the people around the globe has gone through the same level of the stressful situation, anxieties due to the pandemic. Developing countries like Nepal, almost in all the hospitals, there were scars of logistics like N95 masks, PPE, and even adequate amount of, and segregation is very, very tough job for the hospital. Segregation of the COVID and non-COVID patient. And testing during the initial phase was very challenging and very difficult, as we have to rely on the single central government laboratories. But now we are fortunate to have more than 40 laboratories, both private and government, who are doing real-time PCR tests. Implementation of the treatment and admission protocol was equally challenging due to the changing government policies and limit of the resources. Patient transfer is another big hurdle for the frontline healthcare worker, as a pre-hospital care in our nation is still in its infancy, and there is no adequate ambulance services for the care of the patient. Social pressure was significant for the healthcare worker from the home and the hospital and the society. And there were several cases reported that the healthcare worker who were residing in the rented room was verbally and physically abused by the landlord, accusing them that they were the carrier of the virus from their workplace. So this all issues has been gradually settled down by the constant team effort of the hospital COVID response committee. And fortunately, I'm also one of them. We have set the fever screening areas in the entrance of the gate. We have set the well fever clinics and also did the rearrangement of the different areas of the hospital, like registration lobbies, waiting area, emergency, OPD, ward, ICU, and even cafeteria. The use of PPE is basically very new for the health sector here in Nepal. So it was not readily available in the market as well. So hospitals had managed somehow to prepare the reusable PPE from the local available resources like the raincoat materials. Despite of the limitation in the infrastructure, the committee has managed to allocate the donning and doffing areas, and the training of the hospital staff regarding donning and doffing was taken care by the initiation of the infection control committee of the hospital. And implementation of the hospital admission and treatment protocols was set according to the standard guideline. And there, as Dr. Prateep has said, that there were many mental health issues within the healthcare worker, and it was addressed by the team of the psychiatrists of our hospital by multiple sessions of the motivational classes. So this is a picture of our hospital fever screening area. So you can see here, this is the registration lobby. The patient waiting for the registration, they are aligned with the adequate social distancing. In the OPD clinic for acceptable distancing. You can see here a doctor with full set of PPE taking care of the patient in the OPD. So this is I'm sharing the floor plan of the COVID ward that was recently made in our hospital. Previously, it was a private ward. So you can see here in the same ward, we have managed the general COVID ward, step down COVID ward, and even COVID ICU with a designated area for donning and doffing, with also the master control center unit in the same floor. So just want to share our established admission protocol. The patients are basically admitted in 3 respective zones: green zone, orange zone, and red zone, based on the PCR report. All those who have the negative PCR reports were admitted in under green zone, and PCR awaited and need to be sent patient admitted in orange zone, and the patient with positive PCR report were shifted to the red zone. So this is the picture of the swab collection booth in our hospital. Here you can see on-duty doctor with full set of protective gear, which was locally made from our hospital. So here you can see the different level of the staff getting training of donning and doffing. Here you can see our emergency doctors are getting hands-on training for the safe intubation by using the locally made airway protection box. And we are fortunate to have the sister robot which was given for our COVID ward in courtesy of Nepal Robotic Association and UNDP. And here our IT department of our hospital has put their best of the effort for the establishment of Master Command Center unit, where the healthcare professional can have a close supervision of the COVID patient, as well as it has significantly minimized the healthcare worker to the COVID patient. So this is in our hospital. So far, we have taken care of 535, out of which we had 15 mortality. And despite of taking all the precautions, we have 146 of our healthcare staff turn out to be positive, and happy to share that they are all doing well. Thank you for listening.
Dr. Pradeep, you are muted again.
Thank you, ma'am. We are being late, so I'll directly call to Dr. Sital Adhikari, who is MD DM in Pulmonary and Critical Care Medicine, and he works at Chiton Medical College. Professor Dr. Sital Adhikari, sir.
Hello, good evening, good morning, and namaste. Am I audible?
Yes, sir.
Yeah, it's a real honor for me to be part of this experience sharing program from Nepal and from USA, and I'm really grateful to Dr. Dheeraj from small Earth Nepal, Dr. Pradeep from Rotary Club of Kathmandu, and Dr. Vishal, who is my friend currently working in US. So I'm working in a different hospital. It's a medical college, but I fully agree with Dr. Bataju regarding the initial experience of management of the COVID patient. To be honest, we were having training on a lot of aspects, like, just a minute, of giving the training to all healthcare workers about the proper use of PPE and how to prevent the infection control in the hospital. And we also separate the ward for COVID patient, but things didn't work for us in a way that we got permission from the government to admit COVID-19 patient in the middle of July. So when patients started coming to our hospital, it was very interesting to find out that most of the patients were very sick. And we didn't realize that allocating the staff in the COVID ward or in the suspected ward where the suspected patient were kept was real challenge. And other things highlighted by Dr. Bataju, like triage, emergency room, were a real issue for us as well. And the most interesting part, what we realized earlier, is the patients were not really ready to express themselves about the symptoms of fever, cough. And we came with mixing up the patient because the fever was thought to be a very specific symptom. So we didn't get patient easily describing their symptoms, and fever was not reported easily. That was a very interesting part I need to mention over here. And again, the denial was the part. And to be honest, we didn't have critical care team prepared enough to handle the airways, because we thought that handling airway as a sort of aerosol generating procedure is likely to infect us. Still, we could manage. And high flow nasal cannula, which was not there in our hospital initially. So the result was many of us, our clinical team, including supporting staffs, were infected. And like Dr. Badaju was sharing, and almost all of us now have recovered and started doing the job. And later on, when there was the peak of COVID, we were a little bit, I will say, oriented, probably comfortable to handle the cases, and we could identify the patient in early stages, and we can categorize them depending upon the severity as a mild, moderate, severe, and critical. So always on the back, there was the pressure from the media and patient's family about the availability of remdesivir and plasma therapy. To be honest, I don't have a very good experience with the plasma therapy, and we didn't use that as well, because we didn't get that easily, and it was a real challenge for the clinical team to go for those things. And I agree with the previous speakers from USA that the remdesivir we thought is useful if we can start early. But again, our experience with the remdesivir when the patient is severely ill or critically ill is not that good. So what we have done so far is we have tried the patient early, separated the ICU where the airflow. To be honest, we don't have the negative pressure ICU, but still we increased the air exchange rate and dedicated 16 beds ICU and nearby the SDU so that we can keep the moderate and severe or critical patient over there. And entry area and exit area, I mean the door is separated from the main gate, so we could restrict the visitors, which is very common in our part. When a person is admitted, we'll have 3-4 visitors at least to be moving around the hospital. So we could isolate relatively better in the later part of the epidemic. And again, we had now I have 7 high flow nasal cannula, and I agree with my colleagues in the US that most of the time we can avoid intubation and mechanical ventilation if initiation of treatment, that is correction of hypoxia, is started early. And again, we stick on basic therapy, supportive therapy for ARDS patient with like conservative fluid management, giving heparin for prophylaxis, and yes, steroid is started in almost all of the patients nearly after the first week of the illness. And in the later part of the epidemic, I think we could save more lives than what we could have done earlier, because we are more comfortable. We had some guidelines to implement, and we could, moreover, the most important thing is we could identify the patient who is sick or who is severe or critical. So again, the issue of the personal protective equipment, surgical mask, N90 mask, N95 masks were always there. And what we learned from this experience, I'd say, is identification of the patient at early stage of hypoxic respiratory failure and implementation of oxygen therapy properly and high flow nasal cannula can save more life. And again, intubation and mechanical ventilation, to be honest, it was not that good experience initially, but later on we could take the patient out from the ventilators in many occasions. But again, in our part, the problem is a financial issue, because patient or patient party, they have to pay, and it is very difficult to prolong the intubation and prolong the mechanical ventilation beyond 10 days or so. So elderly patient with comorbidities, it was very difficult to continue the treatment in ICU with ventilator support. So I'd say that the lesson learned from us is early identification of the patient who is likely to get worsened, appropriate initiation of oxygen therapy with support of high flow nasal cannula, and dedicated ward to manage the patient are important thing. And we didn't use audio-visual methods at nowhere and not at any time, and we were present there most of the time. And I should be very grateful to my fellows, residents, and especially nursing staffs who were always there around the clock to care the patient. And another thing I need to share is, I don't know what's their experience in the US and in other parts of the country, because we are representing different hospitals. Managing comorbidities, especially diabetes, is a real challenge, and still we see few patients being inpatient because of the uncontrolled diabetes. And to be honest, the final thing is, now the number of critically ill patients with PCR positive have gone down, but we are getting number of patients with long COVID, especially involvement of the pulmonary symptoms. So that's all from my side. And I also agree about the availability of the PCR and these things, making the waiting time long, mixing up the patient with suspected COVID, and these things with previous speaker and speakers from USA. Thank you. Thank you for the opportunity.
Thank you, Dr. Sheetal. Again, I just want to request all the speakers, actually we are going out of the time, so I just want to get precise, up to 5 minutes. So I call upon Rotarian Dr. Prakash Paudel, who is MD pulmonologist and also hospital director of Nepal National Hospital. Dr. Prakash.
Namaste, good morning, good evening. Thank you so much, Smaller Earth Nepal, Dr. Pradeep Pandey, Rotarian Dr. Pradeep Pandey, Dr. Bisal. I feel honored and privileged to be a part of this program. It is a very good program, and I'm also learning a lot from my colleagues, my speakers. Thank you so much. So experience is almost same as our previous speaker, Sital sir, Dr. Batazu. I have the similar kind of experience. So at the beginning, the problem was like what we faced was the logistic problem, technical aspect, and even there was this fear of getting contracted with COVID-19 amongst health worker itself, and there was this chaotic situation within the common people. So the main important problem at the inception of the disease was like getting proper gear for us, for the medical staff, medical health professionals was there. So that was there. And so what we had in mind is that me, myself being a physician, just physician itself and a hospital director, the burden was double because we had to see the treat the patient as well as I had to ensure the safety of the my staffs as well as take care of hospital administration. So what we did was at the earlier phase, we realized that we need to make people aware of the situation and we need to reduce or cut down the number of patients coming to the hospital first number, then getting admitted to the hospital second, and um, uh, stopping people to get admitted in the ICU and trying our best to not to intubate or ventilate the patient. So this was our common fundamental. So to cut down on all this, what we started is at the first point, we started a hotline number, hotline 11474 digit number. We started this and we started getting calls regarding COVID issues and we started addressing the common issues from the public side. We started getting a lot of calls and we started making aware of the situation. We started giving home care services, this kind of things we started this. And at the second point, what we did was like, after as patients started coming to the hospital, the now safety of the staff as well as safety of the doctor and treating the patient was very important. So what we did, we started a isolation ICU with negative pressure rooms. So we built a negative pressure rooms where because of that we could make our staff realize that they are safe, because at the initial phase, making staff do the work as well as because people were very worried about getting contracted with the disease. That was also fear, and some of the staffs were actually leaving the hospital. So that was a very problem. The burden was rising, but number of staffs were decreasing, and some of the people were also getting contracted. So we tried to ensure the safety of the patient. So for this, we did this, and we even started telehealth services. And what we did was like we started this isolation ICU and we put the patient, because at the initial phase, getting PCR done, getting testing was also a very big problem, because only government hospital had this PCR facility and we had to wait a longer period of time, 3 to 4 days, sometimes even 5 days. So at this point of time, we would put the patient in isolation and we would shift a patient as they come negative to regular ICU, and if they are COVID positive, we would send to COVID ICU. So we had these 3-level ICUs, and at that point, what we did was like we changed our NICU, PICU into COVID ICU, and we made this isolation ICU, and our regular ICU was for non-COVID PCR negative patients. So we did this, and we tried to mitigate the number of cases. And in this, what we did was we started telehealth services, because uh, uh, we with the telehealth services, we tried to reduce the number of visit to the patient side as well as reduce the number of PPEs, gowns earned, because this was also a problem at that point of time. So with that, and I installed 2 to 3 mini robot in my different ICUs, and we used to, which was uh, and I have to remotely assess all of my patients through my mobile phones whenever, and I did one round in the ICU. So this way, we started treating the patients. So, during my treatment protocol, it's almost same. What we started at March is not the same as we are now. And now the number of cases in Nepal has a bit gone down because number of, even I would say that number of testing has also gone down a bit, but the critical patients are, the number of actual critical patients are rising, but people are normal patient, mildly symptomatic patients are staying at hospitals in home isolation. So case seems a bit lower, but I don't know how it will go in coming days. So we did this. We tried to do best from our part, and in terms of treatment in ICU patients, in COVID patients, the high flow, because we also didn't have this high flow nasal cannula in our earlier days, and when there was necessity of a higher oxygen demand in the patient, so in that we needed to ventilate the patient, and at our earlier time it was difficult to wean the patient from the ventilator. It was really difficult, but after this with this high flow nasal cannula, we have the number of cases to be ventilated has really gone down, and a lot of patients are recovering, so that's a very good sign. And other treatment guidelines are accordingly, like Dr. Simple and Dr. Pratazu previously said. So this is my experience. I won't take so much time. Thank you so much.
Thank you, Dr. Prakash. It was a wonderful experience sharing from your side. Now we have young and dynamic doctor, Dr. Prabhat Adhikari, who is infectious and intensive care specialist and working in Manmohan Medical College. Dr. Prabhat.
Thank you very much. First, I would like permission to share my screen. I have some PowerPoints, if that's okay. Yeah, you see my screen? Yeah, so thank you very much for the opportunity. This is Dr. Prabhat Adhikari, Infectious Disease and Critical Care. So I would like to share some of the experiences we had during this COVID crisis. So when I talk about the experience we had, it includes a lot of topics ranging from medical to engineering to labs and all. And it's because we work as a team. We have a big team of researchers, other doctors, and also engineers. So we've been working in different fronts with the private as well as government. So first, when the crisis started, we were busy with the guidelines, infection control and clinical guidelines and dead body management guidelines, and then the real infection happened, and then we're busy in formalizing the test and testing protocol and what tests to do. And then the real outbreak was about to happen, and then we team up with the engineers, and we devised something called contact tracing app and learning management system, and we handed it over to the government. And after that, the capital city where we are located was hit by the first wave. At that point, there was crisis with the bed. There were a lot of patients in home isolation. Some people were dying in home or hospital. At that point, we team up and we set up a system called Home Isolation Monitoring System, where we had a team of trained doctors and nurses, and we created virtual hospital and telemedicine and took care of 400 plus patients all over Nepal. And in the meantime, we met a team of young engineers, and we met some ventilators. I'll talk about that. And right now, the first wave is over. The infection is getting outbreak in other parts of Nepal, and we're busy with some clinical research and clinical trial on antiviral called favipiravir. And also there's a team which is involved in vaccine trial, which is the next biggest thing in Nepal. So let's talk about the testing first. So when we first enrolled the PCR technology in Nepal, there was only one government lab and 2 or 3 private labs which did the regular PCR. Now it's been around 40 plus centers all over Nepal. And the first problem we had was there was a problem with the swab collection stick. So forget about the VTM, forget about the other things. The first problem we had was we didn't have the VTM stick. And so what happened is that some of our friends, they bought a Japanese 3D machine and sent it over. And that's where we printed out the 3D printing for the VTM swab sticks, and all these are being manufactured in Nepal. And then first we started with the traditional PCR technology, and now then we moved over to dry swab and PCR, direct PCR. I think maybe you know about that, because initially when they rolled out, you need a special VTM, and you needed a special machine, or you have to carry out the RNA extraction process, which takes around 6 hours. So the turnaround time for each PCR used to be 8 hours or 10 hours, and that was the main bottleneck for the PCR turnaround to be delayed, So with that, what we team up with the team of lab specialists or PCR specialists in US, some of our friends over there, and we rolled out this technology called dry swab and direct PCR, which is already EUA FDA approved, and it's now getting momentum all over the world. And in this technique, you don't need a VTM, and you don't even need an RNA extraction process or even the machine. So your runtime will cut down to 2 hours. And then we have newer technologies like LAMP technology, and also CRISPR. It should be CRISPR technology, which was recently awarded the Nobel Prize. I think you are aware of that technology. And there's a team from MIT, some Nepalese and MIT students who are trying to bring that technology to Nepal. So within next 1 month or so, we'll have a lot of CRISPR technology imported in Nepal. And then there's also a team who work with the Cepheid, and you know that GeneXpert can be used for COVID now because they already have the reagent. And also there are some new isothermal PCR technologies coming over from China and Japan. And I'm in the Aztec committee in the government, so we've been working with those people in those technologies. But looks like the most promising technologies right now for the PCR is dry swab with direct PCR. And the second would be LAMP technology, and the third would be CRISPR, And if you are in a small hospital setup and you already have a GeneXpert machine, then you can do your pre-screening visits with your GeneXpert, but the throughput is very low. It's 4 to 8 per 2 or 3 hours. So that's the main challenge. And the next technology we have is the antigen test, but the antigen test sensitivity that's been rolled out in Nepal, it's only 85%, and that's only in symptomatic patients. If you go for asymptomatic patients, it falls really bad. So we don't recommend that test. But because of the problem with PCR, the price and all, it's being used in Nepal. And the third technology we have is serology testing. And I think for diagnostic dilemma, you can still use serology, because we have had some patients who had frank pneumonia, but they are repeatedly PCR negative. And if you do a serology test after 10 days, it comes out positive. So retrospectively, you can see that it also helps in diagnosis. And besides that, it's been also been used in seroprevalence study that's being done in Nepal, and also it helps in CPT study, convalescent plasma therapy. So it's been widely used. And we have, I think, Abbott's and orthodiagnostics, which also give you the titers of the serology, and it's been helpful so far. And besides testing, let's talk about the contact tracing app. So we team up with some engineers like IT people, and then we made this contact tracing app. So the idea of contact tracing app is that when you look at the COVID, like somebody already mentioned, the main challenge is that you have a lot of asymptomatic or pre-symptomatic patients who contribute to more than 50% of the infection transmission. So if you can't control this pre-symptomatic spread, then you cannot control the disease, and you cannot bring it down, So the main challenge in COVID crisis infection control in the community is catching those pre-symptomatic or asymptomatic patients. And so that's where the contact tracing and quarantine plays a role. So if you do a traditional method like question answers and all, it's not going to work, because we have a lot of patients and we have limited people to work on that. So just like US, I think Google and Apple, they have teamed up and they have come up with a new technology. But before that, I think Taiwan and China and Singapore, they already rolled out that technology, and now it's all over the world. So what we did is that we devised this this contact tracing app. So it does GPS and BTS tracking. And based on that, it catches the positive patients, and whoever comes around that positive patient will get a Bluetooth warning, so that the other patients, other people who are not infected, can maintain their social distance and wear masks, So it's called COVID-19 Nepal app. And it's unfortunately, the government didn't realize the importance of this app. So it has been limitedly used, but so far what has been used has been helpful in creating heat map. And I'll tell you about how it works. So you have three terminologies in IT. They call it geo-targeting, geo-fencing, and beckoning. So if you are from the IT background, maybe you'll understand that. So based on these technologies, you can do a heat mapping. So this is just an example of how we can do a heat mapping of any area. And based on your heat map, you can do zoning and compartmentalization. That's an epidemiological term where you make a red zone, green zone, and yellow zones. And based on that, you target your test and target your source management. So we've been working with the CCMC, the COVID crisis team, in regards to that. And the next thing we did is that we did a learning management system. So I don't know if all of you are aware of that. So with the CCMC, we teamed up with the engineers and we devised a lot of videos and training materials, and whatever guidelines we had, we uploaded in our digital library. And you can easily get the access to that and get all the free education and guidelines, So these are some of the videos. We teamed up with some local hospitals in Nepal and made some guidelines and videos and posted them in the LMS. And if you are using it, just give us some feedback. If you are not, then you can still go there and get the free materials. And you have a lot of guidelines from Nepal and also from outside the world. And then the next thing we did was that we had an outbreak in Nepal, like in Kathmandu. Then we got busy in managing the patients in hospitals and home. So we team up with our team again, and then we devised something called telehealth. So you can see that all these hospitals, blood bank, clinics, people living in home, or everybody, they'll be connected with the doctors through telemedicine in the cloud. So what we did is that we did a virtual hospital through our EMR. I also work in the EMR, medical technology. So we devised a virtual hospital in our EMR, and we connected to our patients through telemedicine. And we so far have seen like 400 plus patients, and all of them, they have each patient will be rounded by a nurse, rounded by a doctor, and if needed, the patient will be rounded by the specialist. And all of this is virtual. And so far, our patients are mostly from Kathmandu. Some of them are outside of Kathmandu, and even few of the patients are outside of Nepal, because there are some Nepalese diaspora who live in outside Nepal, like Malaysia or Singapore. So some of these people also got benefit from our system. And we have all the data, and now we are going for publication. So you can see that we have a lot of data from 400 plus patients. So as the disease dynamics changed, your symptoms and your outcomes and complications also changed. So far, only 5% of our patients enrolled in our virtual hospital got real admission in the real hospital. And we got awarded with the International ICT Award for all the work we did with the medical technology. And we're happy with that, and we're motivated, And then we also team up with some other engineers, and then we set up some ventilators. So what we did is that we made an ambu-based ventilator and tried out in an animal model. So if you can check in the YouTube, so there's a dog. So we team up with the veterinary doctors, and we first devised our ambu bag based ventilator based on Stanford. And then we tried on an animal model that was being euthanized, and it did really work. And then we went for the NMC, and I think we finally got the approval. And now we're teaming with some ventilators companies in US, and we're coming up with a real ventilator, and that's going to be that's already on the way from China. So our prototype is being built in China, but we devised and team up everything in Nepal, and hopefully once it's here, the real prototype of the ventilator will again go for research and training. And then we also try to work on the mask. There was some problem with getting the mask, and also, they were expensive. Nobody could check their quality and all. So if you are aware, then actually you can make your own masks like N95. The way N95 work is through electrostatic force, as you all know. So there is a protocol from Stanford University where you can use a cotton candy machine to make your own mask. So what you can do is that you can make the filter of the mask and use it as a filter, and you can make your own N95 mask. And what you need is an ultrasonic stitch, and that's easily available in Nepal. So NIC, that's one of the leading innovative center in Nepal. They're working on this model, and I think they have made some masks out of that. So even in a small scale, you can really do that, And then the next thing is that we also team up with some civil engineers, and we give this idea about creating negative pressure room equivalent. So in Nepal, you cannot really create a negative pressure room because you don't have that pressure ventilation system, or you don't have the HEPA filter. So what you can do is that it's a WHO protocol, and that's used for tuberculosis. So if you use this kind of airflow system based on exhaust fans, then actually you can get a negative pressure room equivalent in low income setup. So, and that's even mentioned in the infection prevention guideline, and also we've been advocating that for all over Nepal. And now we are teaming up with our team, and now we're doing one of the first clinical trials in Nepal. So what we're doing right now is we're taking this antiviral favipiravir, which is a broad spectrum oral antiviral, and we're doing a clinical trial phase 3 on mild and moderate cases. And a few of the centers are out of the Kathmandu. We have 15-20 centers right now, and we just started that trial. And besides that, so my prediction for Nepal, like if you look at the mortality is really low, but still, if you go for age-wise mortality, it's comparable to the outside world. So Nepal's mortality is low, but it's not going to be low once the disease hits full-fledged. So our age-wise mortality is 7% in 61 to 70 years, which is lower than the outside world, but it's still high. So I think what benefited Nepal is maybe masking, universal masking, because masking, as we all know, also works as a vaccine. So maybe that really helped, and maybe BCG, we don't know. And right now we've over with the first wave, and we're getting first wave in other parts of Nepal. And as a clinician, we've seen some uncommon presentations like pancreatitis, encephalitis, conjunctivitis, and diarrhea as uncommon presentation of COVID, just like any other rickettsial or viral diseases. And as I mentioned earlier, serology is really helpful, and also it's going to help in your diagnosis. So if you have a patient which is 7 or 10 days past the symptoms onset, and they have COVID symptoms and signs in your CT scan or chest X-ray, and they test negative on the PCR, you should really try serology, and you will get the diagnosis, or also check for flu. And lastly, but not the least, I think the mortality of Nepal is going to be much less than the outside world, because if you look at the population pyramids of Nepal, then it's way better, in the sense that we have a lot of younger population on the base and an older population on the apex. So that's why our mortality will be much less, and that's what it's being reflective right now. And of course, lockdown is not going to work. Lockdown is going to slow down your disease. But if that's an Indian study. But every time you do a lockdown, the infection rate goes down. But once you open the lockdown, it's going to open up again. So we have realized that. So the next thing we should wait for is vaccines. So right now there are separate teams within the Ministry of Health, and some other teams, and they're working for getting the vaccines and vaccines trials, and we're eagerly waiting for vaccines. And that's all I have to say. Thank you very much.
Dr. Pradeep, you're again muted.
Thank you, Prabhat. It was a wonderful presentation regarding PCR new technologies, tracing apps, telemedicines, and mask. So now our last speaker for the first session is Dr. Praveen Paudel, who is MBBS doctor and deal with a lot of corona positive patient in Shahid Dharambhakta National Transplant Center. During his period, he became COVID-19 positive. So we want to hear his experience as doctor as a corona positive patient. Thank you. Dr. Praveen.
Good evening, everyone, and good morning to all the members here from USA. I'm honored to be here today, so I'd like to thank Dheeraj sir and Dr. Pradeep for giving me this opportunity. I prepared a small slide, if I can share this with you. Okay. Yeah. All right. So as a frontline worker in the developing country like Nepal, I'm working as a medical officer in the transplant center of Nepal, which is the only government-run hospital dedicated for transplantation. So a little bit background on the pandemic. After the first case in China was recorded in 31st of December, Nepal had quite a bit of time for the preparation to go ahead before it is struck in Nepal. So the first case of Nepal was in 23rd of January 2020, and since the WHO declared to the COVID-19 as global pandemic in March of 2020. So in this period, where were we? So we actually were very short on infrastructures and medical supplies. There were limited numbers of beds and ICUs present in our country. The doctor to population ratio in average is about 7 in 10,000, and there's a huge disparity between them in the Kathmandu Valley, which is the capital of Nepal, and a rural part of the country. Initially, what the government did was it designated the hospital based on the resources available and the patient that they could treat on the level of 1, 2, and 3, which was later expanded to number 5, including the multi-speciality care. So it has been largely replaced recently because the surge of the coronavirus cases have been so unprecedented that this level of preparation is now being updated right now. So the current scenario now is the doubling time has increased and the active number of cases is around 15,000 in Nepal. So according to the WHO pandemic preparedness, our country is in the category 4, which means that the government is mandated to declare the disaster. So you can see the disaster management cycle here. We're currently in the response phase. We soon hope to be in the recovery phase, but we're still in the first wave of the infection. About 1/4 of the cases of the mortality cases are now currently being reported from Kathmandu Valley, which is not a good indications for the control. So after the initial surge of the virus, the government strategies, and the first one was to prioritize the quarantine and isolation management so that the containment of the spread of the virus was possible. So in the present context, patient who is tested positive for COVID is now isolated for 10th day and is discharged from the ICU 14 days, irrespective of the PCR result. So there was a recent article in the Lancet which debates the use of PCR result for more than 9 days in its role in the communication. I think our distinguished members panels can shed some more lights into it. So there were some schemes for community engagement and risk communication, trying to minimize the stigma associated with the contraction of COVID-19 among the healthcare workers and in the general public as well. And a contact tracing team was organized, which included various members of the healthcare, and the number depended upon the population and was about 5 in the metropolitan and 3 in the sub-metro as well. And the surveillance was conducted with a close coordination with Epidemiology and Disease Control Division of Ministry of Health and Population, and the early warning and reporting system was activated, which was previously present for the diseases like cholera, malaria, and severe acute respiratory illness. So the COVID-19 was also kept in the early warning and reporting system, and the screening at point of entry was encouraged, and rapid response team was swiftly put in place. And I am one of the member of the rapid response team in the Bhaktapur. In the meantime, the special attention was given so that these kinds of facilities was not interrupted, like safe motherhood, who needed the frequent ANC checkups, and immunization schedule and family planning schedule, and people with chronic morbidities, and to ensure that there was enough supply of the medications as well. And there was proper running of one-stop crisis management center, which reports any rape or assault cases that happened during the period of this pandemic. Regarding the hospital response, the hospital that I work is the government-run hospital, is a transplant center hospital. So as you can see in the picture, the 3 hospitals, they're very close in proximity. So we collaborated with Bhaktapur and Cancer Hospital. to share the resources and dedicate the single ICU and isolation ward for all the 3 combined hospitals. So in a way, we could prevent the contact of each healthcare workers with rest of the patients who are likely to be contracting the COVID-19. So, and in the meantime, we strengthen the referral mechanism. There are only 10 ICU beds available in the October hospital, including our hospital. So we had a strict strengthening of a referral mechanism as well. And in the hospital setting, infection control was of paramount. So the initial supply of protective gears was ensured, which I'm sure was not adequate given the sheer number of the cases that we had. And the training of the staff was also very vital in the infection control in the early phase of the pandemic and its response. In the transplant center, Ministry of Health and Population dedicated our hospital as a sole institution to facilitate the COVID-19 hemodialysis, especially the patient who was seropositive with HIV and hepatitis. So with over 900 patients, renal transplant patients on regular follow-up, there was no way that we could see those patients in person. So we arranged a telemedicine. We would contact the persons, and the patient would follow up us on the telephone. And the mild cases were managed on the home basis, whereas the moderate to severe cases were then transferred to the hospital. In my personal experience, about 100 cases were confirmed. I'm talking here about the kidney transplant patients. These were the 100 confirmed cases with 3 mortalities in our hospital. There is still a study undergoing regarding the presentation and the indicators that we can see for the further research. And in the though the general population has a mortality rate of only 1%, the transplant patients mortality is around 20 to 30% according to the articles published abroad. So there's no data available for the country right now. We're looking into it, and we're trying to get some more data so that we can put it in a research, but there's no current data available right now. Regarding the clinical care of the patient, it was a multidisciplinary approach. It's in the unprecedented period of time. There's no single specialty who was equipped at handling the COVID-19 patients on their own. So we had a team including nephrologist, pulmonologist, respiratory therapist, and critical care specialist. And the initial problems that we faced was diagnostic dilemma, because the kidney patients, transplant patients who been usually had lymphopenia. So a lot of patients, the lab parameters that we use to see the general public was not readily accepted here in the case of transplant patients. And they had multiple comorbidities associated with their condition as well. And there was a lot of individual decision that needed to be made, because the long-term immunosuppressive the patient were taking, like mycophenolate mofetil, had to be withdrawn, and the serial monitoring of the tacrolimus level was done, and steroids was continued as well. And a peculiar thing about use of the vitamin C in the renal impaired patient was the patient would be at risks of oxalosis. So we are very cautious in using this in the treatment. As I said, the care was very much individualized based on the patient's need. These are some of the medications that were held abroad for a very good response to the COVID-19 treatment. Regarding the list of medication, I'd say I personally had experience with remdesivir. The rest of the medications were lopinavir and ritonavir in the context of renal patient. It increased the TAC level, so it was nephrotoxic, so we best avoided it. And interferon would trigger the allogenicity and increase the risks of rejection, so we avoided it as well. So, and the systemic steroid, when it started early, was very promising in early phase. And now, after all this, working as a frontline worker and contracting the virus myself, there are a few challenges that I'd like to talk about. Is now going forward, vaccine procurement. Recently, government of Nepal just created a committee for the procurement of the vaccine with the foreign governments, which costs about $4.2 billion. So it's a funding and financial issues for the developing country like ours, and the public support behind it. And it's very difficult for a country to maintain the cold chain and set up the infrastructures and train the human resources for the proper vaccination. And we are equipped with immunizing the childhood population. So it would be a first time that we will be immunizing the adult population as a routine vaccination. So it's a good challenge. It's a new challenge for us as well. And moving forward, there are lots of research that have been going on. As I said earlier, there are very few datas dedicated and solely from Nepal. So NHRC has just National Health Research Council has just approved 32 of the proposals for the research. So hopefully we'll get the datas from the Nepalese population with its ethnic variations. So this was a public health aspect as a medical officer working in the government hospital. This is all that I have. Thank you.
Thank you, Dr. Pran. It was a great presentation. So actually now we're going to the second session, but because we have already late, I just want to apologize. Actually, we have planned to have a 20 to 25 minutes of discussion session, but we don't have much time. So we'll take only 1 or 2 questions. So if you want to ask any questions, please raise the hand to share your experiences and to provide inputs. But if you have any queries, you please take the name of the speakers to whom you want to ask questions, so it get more clear in the conversation. So now the floor is open to ask questions or to share your knowledge and experiences. Thank you.
Hello, Dr. Parvit. I'm Dr. Khem Raj Bushal. I just want to hear the experience from US about favipiravir. Dr. Prabhat just said we are doing some research on favipiravir. What is the experience from the US they are using?
Vishal?
I think Dr. Duhek is already left. My eyes, let me see, he's there or no? Oh yeah, Dr. Prakash Kodel is here. Maybe he can give that answer. Thank you.
Yeah, to be honest, we have not used those therapies in our hospital. I know Illhaven Hospital, like main campus, has done some trial. I don't know the result of that trial. One thing we have to use is tocilizumab. We used for several months, and recently even that is dropped out of the protocol. So right now our protocol involves remdesivir and dexamethasone. We never used other antivirals and any other monoclonal except toci. And how was your experience?
Yeah. We are using in mostly in mild cases and some moderate cases. And in mild cases, we are comparing with the standard therapy, that is with dexamethasone and other supplements. And in the moderate cases, we are comparing with the remdesivir. And
how long is the trial?
Multi-center trial is still going on. Yeah, this multi-center trial is still going on. Yeah.
Okay, we'll wait for your results.
Yeah, sure. Thank you.
Thank you, Dr. Kim and Dr. Cornell. It was a great interactions between you. We can take one more questions.
I have questions for Dr. Tucker. Dr. Tucker, is there any possible that we can start telemedicine with the Nepal team in the future and to deal with this COVID-19?
So we're using telemedicine with our providers. Some of them who had high-risk conditions that kept them out of direct clinical care, and they were able to still work and provide clinical benefit from their quote bunker. I'm not sure if that translated very well, but separate area that does not expose them. We have some transplant patients who are physicians and other immunosuppressed people. So I think that there is benefit. I think there's potential there to be able to use people that are sick or unable to have direct patient contact, especially if more healthcare workers are infected. I did mention briefly the use of the Amazon shows. That's a pretty cool, relatively cheap technology that has proved very beneficial. Just like in your home, you can, quote, drop in on rooms very quickly and assess patients. So I think there are some pretty nice options out there, both whether the patient and provider are in the same place or not. That's my experience so far.
Thank you.
Thank you. If we can have a telemedicine facility, maybe we, Rotary Club, also will be more interested on that part. So are there any other queries? Otherwise, we'll end this discussion session. Okay, thank you. So now I request Dr. Bisal Pradhananga to summarize the whole program. He is respiratory care practitioner at Yale Hospital. We'll love to hear his experiences as well. Dr. Bisal.
Thank you very much for participating in this webinar. It's a very great honor to see you all of them, and especially for the team from the Yale New Haven, Lawrence and Memorial Hospitals and Nepal's teams. So this webinar is just sharing the experience and knowledge of COVID-19. And we already know that this is COVID-19 is a new for everyone. So at the beginning of 9 months here, we are all new from the COVID-19. And that time we have like every hour hospital protocols change. So like what to do or what to not to do. So main concern of COVID-19 is the aerosolized problem. So everyone feared that it would spread to the aerosolized. So whenever the COVID-19 patients comes, we saw so many hypoxic patients, like their oxygen level was dropped to 70s, 80s, and the maximum oxygen we can put during that time was 6-liter nasal cannula. If patient on the 6-liter nasal cannula, if the patient's saturations are not improved above 94, we went directly to the intubation and the mechanical ventilations during that time. So high flow was not used that time, but we learned about later on that no, we can use high flow nasal cannula. This is the early intervention to prevent mechanical ventilation, and we see a lot of prevent intubations and patients mortality. So this is the best. And from Nepal also glad to know that like we are also a very good team over there. And the concept of this COVID-19 is if need from here in USA to any coordinator to collaborate in the future, we can think about that. So thank you very much for your valuable input for everyone.
Thank you. Thank you so much, Dr. Bisal. Now we are coming to the end of the program. I request Rotarian Tirtha Dahal, who is president of Rotary Club of Kathmandu, to provide a concluding remarks. Tirtha sir.
Thank you, Dr. Pandey. First of all, I am going to introduce my Rotary Club introduction also. This is our Rotary Club of Kathmandu. This is the Rotary movement on April 13, 1959. Nepal officially entered into the global family of Rotarian. This was the day when the Rotary Club of Kathmandu was started, the fourth club in Nepal. Rotary Club of Kathmandu has been making every effort on attain the objectives of the Rotary through the project focusing primary on the health, hunger and humanity, mega eye camp on TB control, eradication of polio, installation of the first radiotherapy unit at Bhaktapur Hospital, installation of the first cath lab in Bir Hospital, and then the Syed Gangalal Hospital, establishment of the Eastern Hospital at Biratnagar, First Mexa Facial Center of the National Dental Hospital, medical supply to the national hospitals and other health institutions, donation of the several ambulance in the different area, health camp, various scholarship award, upgrading and the equipping the schools, training to the army for their self-sustaining construction of the school building and the providing physical infrastructure for their developments. Children's parks and the improvement of the water supply system and construction of the several reservoirs, formation of the first Rotary Village, RCC, are some of the area Rotary Club of Kathmandu initiated and supported project with the kind support of partners in the several like Inner Wheel Club, Rotary and Interact Club, as well as RCC. Now, in response of the COVID-19, our club, Rotary Club of Kathmandu, established the PCR lab at the Prasuti Griha, hand over the swab collection booth to the Health Ministry, establishment of 28 units of the mechanical hand washing station at different hospitals, public area, schools, police station, jail and university, and distributed the food stuff to more than the 500 family and PPE sets and medical supply for frontline health worker and several providers. This is done by our club. Good morning to the US doctors, Dr. Oliver Morgan, Dr. Kelvin Tors, Dr. Kentia Tosser, Dr. Neil Dweck, Dr. Eileen Burton, Dr. Tommy Summer from USA, good morning, and Dr. from the Nepal, Dr. Professor Dr. Sital Adhikari, Professor Dr. Kavita Hada Vataju, Dr. Prakash Porel, Dr. Prabhat Adhikari, Dr. Praveen Porel. Thanks to all for nice presentation. This is our collaboration of the three partners, the small Earth Nepal, the LR New Haven Lawrence and the Memorial Hospital and Rotary Club of Kathmandu. This is thanks to the Dr. Dheeraj Pradhananga, who is connected to our Rotary Club, and we collaboration that this program also. And thanks to the Dr. Bishal, last week also he presents some idea to us about the how this program is conducted, and at last this program is conducted accordingly the time, and thanks to the all, and especially thanks to the Suresh Chalise sir, advisor of the small Earth Nepal. He give the idea to how to conduct this type of the webinar, and thanks to the Suresh sir, and thanks to the Dheeraj Pradhananga. He give more effort to conduct this program, and thanks to the Dr. Pradeep of Rotary Club of Kathmandu. He is moderate and help to conduct this program. Thanks to our all doctor and all seniors and member of our club. Thanks, and coming time we can collaborate the different type of the activity from the US and other organizations also. Thanks to the all. Thank you.
Thank you, President. So I request Suresh Chalise sir to conclude and to give a vote of thanks to all, and I leave here. Thank you, everyone. Suresh Chalise.
Sir, unmute गर्नु पर्यो. हजुरको म्युट छ सर, सुरेश सर.
Sir, please unmute your mic.
Okay. Can you listen? Can you hear me?
Yeah.
Okay.
Sure.
Thank you, Dr. Pandey. Thank you, doctors. It's indeed a great privilege and honor, but to be the last speaker is also a challenge. Basically, my job is simple: to thank you all. After nearly 1 year of COVID pandemic, and with the announcement of the vaccine now being available in the US, it is indeed a very great occasion that we have started sharing these experiences between Nepal and USA. It's a small step, but which was initially conceived by Dr. Bishal and Professor Pradhananga, Soni Pradhananga. With those ideas we started, and now it has really materialized. We have seen the doctors both from USA as well as Nepal sharing the experience. The one thing that I really missed is the discussion part, because we were expecting some nice question and answer session. Unfortunately, the time was not sufficient. So along with thanks to all the speakers from both USA as well as Nepal, I would also like to apologize to those participants who could not really, intervene or, have a benefit of this exchange of experiences between these two doctors' teams. We are extremely thankful to the organizers, basically, the Small Earth Nepal, Rotary Club of Kathmandu, as well as the Yale hospital team. All of us are concerned with how to deal with this pandemic. It has become a very small world. The world is very small, and that we need to work together. The collaboration is extremely important for us, and sharing of experiences even between the very highly developed countries and those with very little resources, meager resources. I think that might be a very innovative idea. Let's hope that this conversation will continue. I would particularly like to thank the chairman of Rotary, Dr. Tirtha Dahal, as well as Dr. Pradeep Pandey. I would like to thank them who appreciated this and provided this idea to collaborate with the Small Earth Nepal when the idea was first mooted. And now we have got a forum. I hope the next, the moderation by Dr. Pandey was also very effective, very nice. And I would like to hope and best wishes, extend my best wishes to the two events, the two webinars to the general public, and the awareness campaigns that will follow. And what I really wish and hope that this collaboration will continue. And thank you everybody who made it possible. And particularly, I also like to thank those who have not been able to participate, but I hope they will continue to participate in our future program, so that we will see that the time is better managed that time. This is a first experience, so if we have failed in something, so please forgive us. Otherwise, thank you everybody. So bye-bye. Bye-bye and good morning and good evening to all of us.
Thank you.
Thank you. Thank you. Bye-bye.
Thank you. Bye.
Thank you all.
Thank you. Thank you.
Bye.
Thank you. Thank you.
Thank you, everyone. Thank you and bye-bye.
Thank you.
Bye-bye, everyone.
Bye.
Bye-bye.